So welcome everyone back. Thank you for everyone who came back. I will hand you over to Kashif to talk about SLAC and SNAC lesions in the wrist.
So how I can share my screen? Okay. Just give you a slight overview of the SLAC and SNAC wrist, and then because it's quite extensive topic. And then if you have any questions, then we can explain further. Okay, so SLAC and SNAC, these are two most common post-traumatic wrist arthritis conditions, which we see in most of the hand surgery units. And most of these cases, they are presented as a radial-sided wrist pain. And then if you take the history from those patients, they usually have a history of trauma in the past or any history of recent trauma. Sometimes these patients can be presenting with the atraumatic causes like inflammatory arthritis or in neuropathic conditions as well. So coming on the anatomy of the scapholunate ligament complex. So this is a ligament which connects a lunate with the scaphoid, and it is divided into three components: dorsal, volar, and intermediate. Dorsal component is the main component, which is strong and control this movements of the scaphoid with the rest of the wrist. And when you take the detailed history, and then on examination, most of time you will find that the patient is complaining of the radial-sided wrist pain, and most of time they have positive scaphoid shift test or Watson test. And when you go for the radiographs of these patients, you will see there is a different pattern of the arthritis, which can be divided on stages of stage 1, which is a arthrosis between a radial styloid and scaphoid, and then then it will progress further to stage 2, 3, and 4. Most of time, these radiographs on these radiographs, you can see the this widening of the scapholunate area, which initially they call Terry Thomas sign, but recently I come across with a wrist surgeon who say now it's a Madonna sign. I'm not sure regarding that, how common it's called Madonna sign. Anyone come across through that?
Yeah, we hear it. Not sure if that's an official name, but
yeah.
Thomas.
Terry Thomas is most common, yeah.
Yeah, the comedian.
Yeah, that's right. Yeah, American comedian, yeah. Okay, so anyway, so coming to the staging of the arthrosis. So stage 1 is arthrosis between radial styloid and scaphoid. Stage 2 is arthrosis between the whole of the radioscaphoid fossa. Stage 3 is arthrosis of the radioscaphoid and capitolunate articulation, and stage 4 is pain scaphoid arthritis. So broadly, the treatment options are either do nothing, or you can start with the conservative measures with a wrist splintage, and then you can give injections. You can go for denervation to start with, and then if further options are either you can do the radial styloidectomy in stage 1, and then you can progress either to limited carpal fusion or 4-corner orthodesis. So that depends on the stages of the disease itself. Coming to SNAC wrist Scaphoid Nonunion Advanced Collapse. So in SNAC wrist, proximal scaphoid fragment usually remains attached to the lunate, which rotate together during extension, while distal scaphoid fragment rotates into flexion. And this results in abnormal contact in a radioscaphoid compartment, which is characterized by arthrosis of the radial styloid, and then it will progress further to pain carpal arthritis. I think everyone knows this staging, which is a stage 1 is arthrosis localized to radial side of the scaphoid and radial styloid. Stage 2 is a scaphocapitate along with stage 1 disease, and stage 3 is a periscaphoid arthrosis. And radiographic findings are there is a narrowing of the radioscaphoid, and then in stage 1, in stage 2 it will progress to capitolunate. You may find cyst formation, and you may find carpal instability in terms of the dizzy deformity. I think regarding kinematics and carpal instability, I have made another talk which is a little bit detailed. I think we can do this next time. And again, on the angles, the scapholunate angle should is a more than 6. Sorry. So the radiograph, you will go for AP and lateral view. So there are 2 different angles which you need to remember. Scapholunate angle should be more than 60, and capitolunate angle should be less than 30. So these are the radiographs which show the stage, looks like stage 2. Coming on the differential diagnosis, as I mentioned earlier, most of these patients, they are presenting with radial-sided wrist pain. So you can start from the soft tissues in terms of decurvance disease, FCR tendinitis, then SLAC, SNAC, and then that is divided into different stages. If patient is presenting with the mid-carpal symptoms, then you can add carpal abutment syndrome as well in the differential diagnosis. And coming to the management of the SNAC wrist, again, it starts with do nothing, wrist immobilization with the splints and NSAIDs. You can give some, injection of the steroids. And then operative management will be, again, depending on the stage of the disease. So it will be same. It's either radial styloidectomy, wrist denervation, scaphoid excision, then proximal row carpectomy. And the final option will be either limited carpal orthodesis or 4-corner fusion. And the last option will be wrist orthodesis in severe disease. This is a type of the 4-corner fusion with one of the plates, which they fix all the 4 columns of the wrist along with scaphoidectomy. Any question, guys?
I think we just add a few questions.
Yeah.
Obviously, it's a very difficult topic, and I think just want to highlight that you don't really need to know more than what Kashif has presented for the FRCS. If you dig into it, you will find massive books written about these 2 topics, and so you just need to stay safe and know the principles. But,
yeah, just the broad topics, the stages and basic treatment, I think.
Yeah, I think one of the question is about in SNAC and SLAC. What is the last joint that could be affected in the process of these 2 conditions?
Because the disease starts, so it starts from the radial styloid, then whole of the radial fossa, then it will go to the capitolunate, and then it will be periscaphoid.
Okay. And there is one more question, which I think is important from Damo, is about when it comes to patients in the clinic. if they present with the scaphoid non-union, do they all progress to SNAC, or they're,
So
the
disease progression is very variable. So if patient is coming to your clinic and if patient is symptomatic, then it's likely to progress and you have to treat. If patient is asymptomatic, because sometimes you find GP referral, X-ray shows or radiograph shows a non-union, and patient is completely asymptomatic, then you don't need to treat asymptomatic patient.
Sure. Okay. So you can watch them. Yeah. You don't have to.
You can watch that, because I've seen 3 patients in a last 6 months, which was referred by the GP. On the radiographic findings, they have done the X-ray for some other reason. They found the patient has a scaphoid non-union, and when we take in the detailed history, so patient say, "Oh, I fell down a couple of years back, but I don't have any pain over there."
Yeah. Now, David, want to say something?
Yes, again, just to reiterate Kashif's point, it's symptoms rather than sort of radiological findings. So, yes, if you X-ray everyone with a scaphoid non-union, they will have some form of arthritis, but not everyone will come up with pain. Now, I think there was a question from Mohammed to everyone who's asking about pros and cons of proximal row carpectomy and four-corner fusion. Proximal row carpectomy now, I think, is becoming more historical operation. The one big pro for it, though, is it is a quicker recovery. So with a four-corner fusion, you have to wait for the bones to fuse before you can get the patients going. So people do talk about a lot of stiffness, but it is a more robust sort of procedure. With regards to there's another option, you don't really need to know much about it other than they might say, is there anything else in terms of options? And that's wrist arthroplasty. You can say this is novel, it's only done by experienced surgeons of experience with it, but it is a limited use and it's still very controversial. That's all you really need to say. If they push you for it, don't mention it unless they ask you about it.
I think Shwan also wants to comment.
Yes, sorry. Very, very nicely presented, guys. David is correct. You don't need to know too much about this, but there is a couple of points that you should always bring up when you're talking about management plans generally, not just for this. You have non-operative versus operative management plans. Okay, do not say something like "do nothing." Right?
Because do nothing is one of the options which come up according to this consent process.
Yeah, no, I appreciate that. I do. But what I mean is, if a patient's presenting to your clinic, don't say I'm going to do nothing. Say I'm going to exhaust non-operative management plans, such as pain relief, analgesia, pain relief, splintage, physiotherapy, activity modification, and steroid injection as a last resort in my non-operative tree. Once, presuming that has been exhausted, then I would offer this patient. So do you see the difference? And Kashif, I'm not criticizing what you're saying. You're absolutely correct. This is an option in the real life clinics. But in the exam, that's doing nothing is not something you're going to say. You don't say it that way. You say, I have non-operative management plan versus operative. And if the patient says, I don't want to do any of that, then that's the examiner can you leave it alone, or telling you that there's a third option we haven't discussed.
Thank you, Shwan. A question to Kashif now. Kashif, is capitolunate arthrodesis an option? Just, an isolated capitolunate arthrodesis? Is that
No,
I received this question.
No, not just a capitolunate. No,
that's fine. So that answers Atif's question about it. Yeah.
Coming to your option of the wrist arthroplasty, I went to this one of the courses in the OR UK. The guy from I think he was from Essex.
East Grinstead.
Yeah. He
loves it.
He loves this wrist arthroplasty option.
Okay.
Now, guys, be wary about suggesting novel operations. Okay, I know you're working with wrist surgeons, and Kashif, I really appreciate your real life knowledge is far more than me, and David as well. But we're talking about exam technique.
Yeah.
Do not bring up novel operations or operations done by highly skilled surgeons.
No, that's why I not mentioned even in my options that I will go for it.
Oh yeah. No, I just wanted to make sure that you're aware that they might proffer that as another option. Only talk about it if the examiner mentions it, and just say you understand it is done in highly specialist centers with experienced surgeons, but it is not part of your standard practice, and the jury is still out on it in terms of research sort of numbers. It's just, I don't want people to be thrown by wrist replacements. If the examiner may throw it at you, as I say, it isn't something you should offer as an option. It's only if they question you about it.
They may try to throw it at you on a younger patient to see if
Yes,
particularly
as well. So that absolutely not. Fusion is the only option for a younger patient. Only in the elderly or the rheumatoid patient can you consider.
Good.
Yeah,
I think.
There are few sorry for asking. There are few regarding this proximal rocarpectomy. So if a capitate is migrated proximally, then you can't go for proximal rocarpectomy. So you need to they need to keep in mind because with the proximal rocarpectomy, the rehab is quicker and patient satisfaction rate is 50-50 as compared to the wrist orthodesis. With the wrist, not wrist orthodesis, four corner fusion. If patient is young and they need stable wrist, then option will be four corner orthodesis. Although the chances of that non-union and all other risks are still there.
Great. I think that answers Amit question. He wanted to know, in a young patient, what do you do as opposed to older patient? Does it affect your management?
So the old option for the older patient is a proximal rocarpectomy because satisfaction rate in the older patients are high. But in the younger patient, suitable option will be four corner fusion because they need stable wrist.
That's great. Thank you. Thank you, Kashif. That's a great answer. Can I just...
Sorry, just one more option.
Go ahead,
Pancarpal fusion from distal radius across to the metacarpals, used only for patients that have severe arthritis with stiff, but are in the manual labor phase of their life. That's another option. Again, you just need to think about the options. Kashif is correct. Four-corner fusion is usually the one you go for.
Good. Thank you very much. I think we have Athar with us, and he recently passed the exam, and he's kindly joining us also to support the group. And he's been asked a question around this topic in his recent exam. Maybe he could, enlighten us also with his experience.
So, hello everyone. Can you hear me?
Yes, we can hear you, Arthur. Yeah.
Yes. No, I only joined because me and Kashif are partner in crime. I just thought, I'll support it. So
thanks for joining.
But yes, I've been asked this question in the exam. It comes up with all the so it comes up with a very odd-looking X-rays with Terry Thomas sign positive, and he says, "What is it?" So the first question was: young laborer, 40-year-old, had a wrist injury 5 years ago, has been struggling with the wrist and radial side pain, but can go to his activities of daily living, still work as a plumber, and came to your clinic because he had enough. What can you see on the X-ray? So what you see on the X-ray, you see a increased distance between radial scaphoid and lunate. You see radial styloid arthritis. You see scaphoid involvement, and if the capitate is migrated proximally or not. So in my one, the capitate is migrated proximally. Then he asked me, what are the parameters? So as Kashif bhai mentioned, scapholunate angle and capitoscaphoid angle, plus the disruptions of the gluli lines and carpal index. You can bring it in So 3 radiographic parameters will do. Then, of course, the Viva goes on onto which joint involves first, and why is the pan-radial arthritis, pan-scaphoid arthritis is the last. Why is the proximal pole of the scaphoid get involved last? So that is secondary to the kinematics, as it becomes ball and socket joint, and it typically gets spared, and it only get involved once the capitate start migrating proximally. So these were the things to say. And always in exam, always patient was, I had few other people as well who have been asked this topic. The patient stays asymptomatic, so treatment stays on non-operative management only, and very rarely progress to all these controversies of four corner fusions and rest. If it goes there, then before doing four corner fusion, these days they say do a wrist arthroscopy to see the state of lunate fossa, to see if there is arthrosis there or not, because the whole of the four corner will be resting on that. I'm not a wrist surgeon, so my knowledge finishes there. I'll probably stop. But in my exam, I stopped at scaphoid removal and styloidectomy plus a neurectomy, both AIN and PIN, and that's it.
That highlights the importance of sticking to principles here and not talking about anything controversial. And as Shwan said, it's you could say I'm aware there is various procedures if you know of them, but stay safe and stick to principles. Good. Any further comments from the mentors, or anyone else has any questions?
I think there's a question from Amit and Atif about motion preserving procedures in the young. Again, as Atta was saying, listen to the examiner. Asymptomatic. That's the key there. If they are symptomatic, again, a neurectomy is a good option if they want to preserve any motion. However, function is the most important thing. And if they're doing a hard job like a plumber or a laborer and they've got a lot of pain, then a fusion really is the only robust procedure at the moment currently sort of tried and tested. That's my understanding. I don't know if Kashif agrees with that one. Certainly.
Coming to neurectomy, so if you're mentioning the option, so neurectomy is your option before proceeding for any bony procedures.
Yes, yeah, as I say, neurectomy is a first port of call if pain is their main problem. But as you said earlier, you want to maintain a stable wrist, particularly if they're a very active person. And unfortunately, the only way we have currently at the moment is a fusion. It's not a great option, but it's the only, in terms of the BSSH, that is accepted sort of thinking.
Brilliant.
So just to summarize how you manage a young person presenting to you symptomatic, let's say, for the moment. First of all, activity modification, analgesia, splintage, physiotherapy, and finally steroid injection. If the steroid injection gives symptomatic relief to the patient, if it's temporary, consider doing an AIN and PIN neurectomy with a radial-styloidectomy and scaphoid, if required, scaphoid removal. Scaphoid, distal pole scaphoid removal or total scaphoid removal. Then you're looking at your fusion procedures and go stepwise with four-corner fusion, maintaining range of motion. But if it's a patient who needs his wrist for power, grip, and strength, you may consider doing a carpal fusion across to the metacarpals. These, just keep it simple. Go stepwise through everything what you're saying. Don't get into the controversies, and just say, this is how I would manage this patient step by step, okay? You don't start jumping straight into, he's a young fit guy, I'm going to give him fusion, if you haven't talked about non-operative options first.
No, if you answer the way Hashwan has done, they will just sit back and smile and be happy with you. That's how, if they ask you about management of it, that's how you should answer it.
Good. We just have one final question, Kashif. Just we have a question about this. You mentioned the ball and the socket joint.
I think Attar has mentioned this ball and socket joint. You know that when a proximal pole of the scaphoid that is still attached with the lunate, so then that acts separately from the scaphoid.
So basically what happened is, because scapholunate, yes, the proximal, it's a SNAC. So the non-union happens at the distal pole, and the proximal pole stays there, and it stays with the lunate, and that becomes ball and socket. It is explained in few lines in the new Vanaskevich as well. So have a read. I may forget something, so please forgive me for that.
Thank you.
That is what it is.
Thank you both for explaining. I think we coming towards the end of this session. Thank you everyone who attended, and thank you for the mentors, particularly to Kashif for this nice presentation. Next